My friend Boris Simon came up with this lovely diagram which depicts the pulmonary arteries in blue and the pulmonary veins in red. And note that there is enlargement of the pulmonary arteries and veins, where the arteries and veins of the lower lobe remain larger than those of the upper lobe. This is an uncomplicated left to right shunt. In order to see prominent pulmonary vasculature, the pulmonary to systemic ratio of blood supply should be 1.5 or greater, close to 2 to 1. But occasionally the intrapulmonary vessels do not have adequate compliance, and radiographically, despite there being a large left to right shunt, there may be a minimal or no enlargement of the pulmonary arteries and pulmonary veins. This patient exhibited the Eisenmenger syndrome, secondary to a very large, long-lasting atrial septal defect. Note that the heart is markedly enlarged. Note that the right atrium particularly is very prominent, as well as the central pulmonary arteries. Some appear calcified because the patient developed thrombi in the pulmonary arteries with secondary calcification. Peripheral oligemia is also seen. So at this stage of the game, we cannot be sure that this patient does not have a precapillary pulmonary hypertension. The history was that once upon a time the patient had a split second pulmonic sound, evidence of a left to right shunt. It was a woman, and eventually the patient became cyanotic. When that happens, we can then predict that structural changes have occurred in the pulmonary arteries, and that the degree of shunting has diminished, except the intracardiac shunting that can reverse. Instead of being left to right, becomes bidirectional and eventually predominates from right to left, and that's why the patient becomes Note in the lateral view of the chest the enlarged right and left pulmonary arteries, and in the enlarged right ventricle. The patient obviously had precapillary pulmonary hypertension in addition of having a left to right shunt. This is another example of a left to right shunt at the stage that is called Eisenmenger physiology. The patient developed a very prominent pulmonary trunk and central vasculature, and the right atrial border, which originally was prominent, now does not appear enlarged. At this stage, structural changes have occurred in the pulmonary vascular tree, and this is what is called the hyperkinetic pulmonary hypertension. When the large left to right shunt or prolonged left to right shunt leads to structural changes in the pulmonary vasculature, the shunt becomes bidirectional and eventually may predominate right to left. At that stage, the patient may become The lateral view of the chest shows marked enlargement of the pulmonary trunk. At this stage of the game, the patient developed pulmonary hypertension due to a large left to right shunt and was in the so-called Eisenmenger syndrome phase. Another cause of a left to right shunt would be an aortic pulmonary window. And this is an MR study which shows the communication between the ascending aorta and the pulmonary trunk. Vascular plethora can be expected to occur in such a situation. Another cause of vascular plethora is the total anomalous pulmonary venous connection to a common pulmonary vein. Note in this coronal MR examination, a common pulmonary vein receiving the pulmonary veins of the two lungs and draining in the superior vena cava. The figure of 8 of Albers can be expected in such a situation. The common pulmonary vein will produce an enlarged superior vena cava. There will be an enlarged right atrium, and there will be vascular